My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs. Welcome to our HHS Town Hall for Thursday, February the 18th. We'll be talking about updates in our pandemic response, as well as some other operations matters. We have a roster of speakers, and then they'll have a time for questions at the end of that, and as well some celebrations. So just ask everyone, if you can, hold your questions until the end of the presentations, just in the event that perhaps one of the presenters does address the topic of concern for you. You'll have a chance then at the end to also raise your hand and ask a question live if you'd like, and celebrate some people live. First, I'm going to hand things over to our President and CEO, Rob McIsaac, to kick things off. So Rob, over to you.
Yeah, thanks very much, Aaron, and good morning, everybody. Thanks all for taking the time to join us today. We've got a lot of ground that we're going to cover today. You can see, including an operational update, some, as usual, the virus projections and modeling, news about vaccine distribution, in particular second doses, and also the thinking around the large-scale rollout of vaccinations in Hamilton. And some further discussion about yesterday's announcement regarding self-isolation pay for Hamilton Health Sciences staff. The provincial government has signaled that it's expecting a more stable and consistent supply of the vaccine in the weeks and months ahead. This is welcome news for all of us, and we're eager to get going on a full-scale rollout of the vaccine to everybody. Of course, at HHS, but also in our community. Yesterday, Public Health also announced the first confirmed case of the UK variant in the community. So as much as we're starting to see the end of this, it's not that there aren't any clouds on the horizon. So Dr. Mertz is going to discuss what this means in more detail, but it definitely reinforces the need for all of us to remain vigilant and adhering to all of the public health measures while at work and in the community. At Hamilton Health Sciences, we've augmented our pandemic response with the implementation of self-isolation pay to further protect people working within our hospitals and our patients. Other hospitals in the region are doing the same. So this is a coordinated effort within HNHB. We want to ensure that our healthcare system remains positioned to deal with this pandemic in the weeks ahead. So as I said earlier, we'll talk a little bit more about this approach during the town hall. As always, I want to express my sincere gratitude to everybody at Hamilton Health Sciences for being here, for our patients, our community, and for each other. This pandemic has required so much of our attention and energy, and I'm so proud of our staff and our team because they've continued to rise to the occasion each and every time. I'm definitely looking forward to the day when I can tell you that we're in the home stretch and that this pandemic is almost in our rearview mirror. We're just not there yet. So once again, thanks very much, and I will turn it over to Sharon Pearson.
Hi, good morning, everyone, and thank you, Rob. So I have a little bit sunnier update today, although as Rob mentioned, there are a few clouds still on the horizon. As of this morning, we actually do not have any units in outbreak at HHS. We know that that can change quickly, but it is a moment to celebrate right now in that we do not have any. Our COVID numbers are sitting just at 30 today. And I'm sure if folks have been watching the numbers, you know, we had reached as high as 100 previously. So quite a reduction we're seeing right now. Of course, all of the regional provincial directives with regards to how we manage our system, how we balance the activity and don't unduly burden an organization across the province remains in place. In the bottom right-hand corner, you can see the number of transfers as part of that census balancing activity that's been occurring. So to date, 9 related to the COVID transfers to the Hamilton General Hospital. Lots of activity remains with our partners in the community, with St. Joe's, and along with our regional planning committee around how we manage our activity and the transfers across the hospitals. I'll just go to the next slide. We update every time we have the town hall and the Grace Villa, and the good news is that the staff that we have had, with the exception of our leadership staff, are back to HHS, and we're working with the ministry and Grace Villa on a transition plan to bring that home back to stability. The report out from public health this week does show that we're seeing a reduction in the number of retirement homes and long-term care homes and outbreaks, so that's good news. And work continues in the vaccination area with all of those congregate settings, so that's even better news. So nothing more to update on the operational activities this week, but happy to take questions, and I'll hand it back to Aaron.
Thanks very much, Sharon. Next up, as always, we have an update on the epidemiology of the pandemic from Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control. Dominic, over to you. Tell us what's happening this week.
Yeah, thanks, Aaron. I would say in general, the same trends that I've been showing over the last couple of weeks. You see a lot of green arrows here. So most provinces, the typically heavily impacted provinces, are continuing to reduce the number of cases. Saskatchewan continues to be the one with the highest rate per 100,000 per week, sitting at 100. We are at roughly half of that, with 50 currently, or 49 in Ontario. There's a couple of red arrows, and you may be well aware. I mentioned Nunavut last week. Unfortunately, still some spread ongoing there, given the small population, resulting in quite high rates. And Labrador, Newfoundland as well, with 49. And as you may be well aware, that's the B117. So this variant that was first identified in the UK, which is responsible for this blip that they are currently going through. The RT value in Ontario is slightly lower again today, despite the fact that we've seen another day with more than 1,000 cases. But it looks like the decline is coming slowly but steadily to a plateau. Next slide. This is how the numbers looked like as per yesterday for the province. You see this well-known peak and how it nicely came down ever since. Again, the last column here, please disregard, because this is just changing throughout the week. But we are sitting at, as I said, roughly 50 at this point. I put the line slightly lower based on the last couple of days. So we are now comparable to where we were sitting in the week 42 to 45. So that would be October 2020. Next slide. In terms of hospital admissions across the province, the trend continues as well, with lower numbers, 794 in the last week, well below the current peak, but also below the first peak from back in spring 2020. ICU admissions also declining, but quite slowly, as you can see with those dark red columns embedded in here. Next slide. The Hamilton view here, again, similar picture as for the province. We're also sitting where we had been back in end of September, going into October in terms of case numbers per day per 100,000 per week. I would sort of anticipate another increase now, given that we see some issues in our shelter system. with some localized outbreaks. And given that we are currently sitting at 40 to 50 cases per day, if you're adding in 10, 20 cases per day due to outbreaks, this also already looks as if it was a major bump that wouldn't have been or wouldn't have had such an impact when you're already at, let's say, 200 cases per day, or 150 to 200 as we've been during the peak time. Next slide. This is the other view that I'm sharing, which is the community cases per 100,000 per week. So takes out the outbreak associated cases, the close contact. So basically taking out everyone who knows that they had been exposed, which gives you the best feel of what's the risk for the average person out there to be positive without knowing. And here you see that the curve continues to fall quite significantly again. What's in the gray here will increase slightly again because there's unknown cases in there, which most likely are community cases. But we are clearly far below the 20 threshold. And you remember the 20 threshold is when we implemented asymptomatic testing and other policy changes. We will reassess that beginning of March, depending on where we are heading to, given all the uncertainty where the variants and the reopening at this point will, or how it will affect us. And I will come back to that. Next slide. In terms of hospital admissions within the city of Hamilton, we are at lowest ever since week 48 with 44 at this point. And similar to the provincial picture, the dark red bars show a slower decrease. So the ICU, we see a delay in the numbers of COVID patients being admitted, how they decline. Next slide. That's the modeling from February 4th that I've shown you, and I was a little bit overly optimistic here. Today we were sitting at 1,000 cases again, but it may be the outlier or it may be the new truth. We will see, but we pretty much followed this best case plausible scenario based on their modeling with a 5% decrease over time, which is the good news. Next slide. Let's have a look at those variants before I will show you the modeling and how the variants may affect our next few weeks and months. So what we see predominantly in Ontario in terms of variants of concerns or VOCs is the lineage B117. So that's the variant first identified in the UK. A total of 338 cases to date. This was by yesterday, wouldn't have included, for example, the one case, the first case that was identified in Hamilton yet, and probably several others as well. So those numbers will continue to increase every day. Then you have lineage B1351, that's your South African variant, where we have small numbers, 6 to date. And P1, that's the variant out of Brazil, we have 1 case so far. So first and foremost, if variants make a difference for us, which we expect to happen, at least to some extent, it will be driven by B117. Next slide. And this is from the modeling from last week. And this is under the assumption that public health measures are lifted. So the question then becomes, to what extent are they being lifted, in which region, etc., etc. So this is relatively rough and with a lot of uncertainty, obviously. And you can see 3 scenarios here. A plausible worst case scenario, and that's what's been looked at by the media first and foremost, with 18,000 cases by the end of March. To the best case scenario, taking B117 into consideration, where we will be sitting at roughly 2,000 cases again by end of March. You also see the dotted line at the bottom. That's what we had been following so far, which is that 5% decrease over time. Then the question is, at what point of time do the variants become dominant and may actually drive up our case numbers despite the measures that are currently in place? All of this being said, while it may be more challenging to control B117, it's possible, as multiple countries have shown, with the exact same measures to be put in place that we put in place to come out of the second wave. Next slide. I was asked to bring double masking back. I touched on that last week already, and again, I was amazed by how much media attention an experimental study resulted in, while there's many important RCTs being published every day that don't even get close to as much media attention. But it's about masks, so everyone jumps on it. So these are the three scenarios they looked into in this experimental study: medical mask, then a cloth mask on top of a medical mask, and a medical mask with a knot here on the side, very close to the mask. And then they looked at quite tiny aerosols and to what extent the amount of those can be reduced with any type of these masks. And bottom line here is normal surgical mask on the source plus the receiver, and that's the scenario that we have in healthcare. Our receiver, so that would be the healthcare worker, would always be masked. If we can mask the patient as well, and assuming this was real world, which it isn't, but just assume that's the case, it would reduce the number of micrograms of particles by 84%. If you put a cloth mask on top of the surgical mask, it's 96% if you knot your surgical mask. So that's variant C here. It reduces the microgram of particles to 96%. Now, I would also like to highlight with the normal surgical mask, receiver only, they resulted in a 7.5% reduction. Now, if that would mean that it only prevents 7.5% of all potential transmission, everyone who have had contact with any positive patient or staff would have ended up with COVID-19, which certainly wasn't the case. So I would be very careful generalizing from these numbers to transmission. So a 95% reduction doesn't mean a 95% reduction in transmission events. And I think that's something the media didn't get necessarily, and certainly many people didn't fully understand. Next slide. And then there are several limitations to all of this. So it's not real people, it's mannequins that they used with one specific shape of the face and one specific type of medical mask used, which resulted in a very bad fit. So if you're looking at that picture, you see that big gap on the side of the cheek there, which may occur in some humans, but certainly not in everyone. So the way the experiment was set up for, medical masks were kind of prone to fail, and the effect is probably overestimated of any of those measures that they added to improve fit. And as I already touched on, they used a surrogate outcome using particles smaller than the vast majority of particles that are generated by a coughing individual. And the experiment was really, you have someone coughing, right? And it remains entirely unclear how this percent in decrease of microgram of particles actually translates into reduction in risk of transmission. It's no real world data at all. It's an experiment with mannequins. Take-home messages from this study certainly are that what I mentioned previously, N95 with a mask on top, which isn't what they looked at, but that's the most important piece in my mind, must not be used. So never double mask with an N95. It negatively affects your fit of your N95. And actually, the Ministry of Labor wouldn't be happy if they saw you doing that. So that's simply a no-go. Now, based on this study, the question came up, well, should we put a cloth mask on top of a medical mask because of what they found? Again, it's not a real world experience, and cloth masks come with risk. They may get contaminated. It's more challenging if you're doffing 2 masks rather than 1. Who makes sure that this cloth mask gets washed regularly? And who tells you that the cloth mask necessarily has a better fit than your medical mask? It may have an impact if it has a significant better fit than your medical mask, but it should not be the solution. And I think we have pretty much agreement across the province that they must not be used in healthcare facilities. We don't want to see cloth masks. All of this being said, that fit matters isn't necessarily a surprise. And we don't see any risk with the nodding strategy. So if you have a face that where the medical mask doesn't fit well, and with nodding, you can improve that, in particular that gap over the cheeks, please feel free to do so. Nobody will prevent you from doing that, and it may actually come with a benefit. And if not, at least there's no harm associated with it. I can tell you, for me, I tried it with my face. I'm better off with the medical mask with no nods, but someone with a smaller face may actually benefit from the nodding. So that's certainly a strategy you can use. And we shared the document summarizing the entire study in more detail. I believe that was last week. And we added a couple of YouTube links there that explain you how to do those nods, if that's something you would like to try. And the other piece that really came out of this is the benefit of wearing a mask for the source. So again, encouraging patients to wear the mask for source control comes a long way, regardless of whether it's a medical mask, whether it's a cloth mask, whether it's a well-fitted mask. It will reduce the risk. Handing back to Aaron, I expect some questions around this, but that was my summary of this study.
Thank you very much, Dominic. Interesting and informative as always. Next up, we have Leslie Coche, our VP of Clinical Support Services and Surgery, to give us an update on the ongoing work around our vaccine distribution efforts. So Leslie, over to you.
Thanks, Aaron. I just want to tag on to Dominic's comment that from the PPE task force, probably within the next week, we are going to do a helpful hints tip sheet on how to make sure your mask fits well. So look for that information and those updates to come in the daily updates that are broadcast through the hub to everyone around masking. So if I switch to what is really some positive message today on our vaccine updates, Rob has started to tell the story in that our line of sight to our Pfizer vaccines is much more stable right now. So we did receive delivery this week, and we have confirmation of delivery coming for the next 2 weeks. Confirmation that it's planned. It's never confirmed till it's in our freezers. But looking at about 5,800 doses a week coming in. So that's meant some really, really good news for both our teams and our patients. So the Fix Clinic at 293 Wellington is in the process of calling out and booking for second doses for about 6,000 healthcare workers between St. Joe's and HHS, and some long-term care workers as well. Those second doses will be needles and arms between February 19th and hopefully finishing the 25th or the 26th. I just want to pause here and give a really heartfelt thanks. So I'm kind of jumping the celebrations. But we have a group of colleagues who have been our schedulers in this vaccination clinic, and sincere thanks to them. They've worked extremely hard to get people's vaccination appointments for second doses in between day 35 and 42. I'd like to thank everybody for their cooperation, because we're really confident we are getting people who are in Hamilton vaccinated within those timelines. And it's really just been exemplary teamwork. So thank you for accommodating your appointments, and thank you to the clinic for all that work. The really good news is that starting 25th/26, we're still finalizing the timelines. We will be in a position to start resuming first doses for healthcare workers. And I remind everyone of whom's in the definition of healthcare worker. It is our frontline team, staff, physician, residents, our learners. It is people who support the work from our colleagues in environmental services, our diagnostic imaging, MDU teams. It is everyone who is forward-facing, touching patients. The really good news is over the weekend, the province did publish version 2 of the sequencing framework. And the language has changed a bit, but the basic groups that the province is giving us is very similar. They still identify the highest priority groups to be vaccinated as our frontline teams in emergency, the ICUs, the COVID unit, the COVID assessment, our vaccination clinics. They then simplify things for us from the hospital perspective, and the next group to be sequenced is everyone else working in the hospital who is forward-facing patients. So the good message to them, I assume the majority of people listening today, as we start to call out to schedule appointments starting February 25th, 26th, we will be calling essentially everyone who's registered in the tool, who's in work that is forward-facing patients every day. We are working with St. Joe's, and this has been happening really quick this week. We will publish the revised sequencing framework. So if you have any specific questions over where do I fit in those groups, you'll see it in the revised framework. We're not quite done to share it with people, but we anticipate it'll be out in the next 2 days. We don't want anyone to hold back from registering. Just register to the old sequence and we can move people around behind the scenes. So if I can go to the next slide, please, just to share some other really good milestones from the patient perspectives. So all of HHS and St. Joe's, ALC, and our satellite health facility patients who want vaccine have been vaccinated. Work is underway with public health to vaccinate our patients who are at St. Peter's over the upcoming days weekend. From a city perspective, we should be super proud of the work with public health in that all of Hamilton's long-term care facilities and our high-risk retirement homes have been completed. And the plan is next week that the balance of the retirement homes will be vaccinated. So if we look at the burden of COVID coming from our elderly, frail elderly people, and especially those in long-term care, this is a really, really positive message that those patients or clients have been vaccinated. The third bullet is probably really good news for a lot of our parents. And that is that aligned to the provincial direction, the city of Hamilton will start to roll out vaccination targeted to individuals who are over the age of 80. So the details of this plan is still being confirmed. It will be through public health. The early strategies will be elderly people coming to, over 80 elderly people coming to a designated clinic that's being established. And right now we estimate that's another 20,000 people in the city. So with all of the good news, I hope as I finish, people hear the message: forward-facing healthcare workers, students, learners, everyone who wants a vaccine will get one. And we anticipate that to be over the next few weeks, starting on the 25th. And I don't want to sign off without reminding someone getting a vaccine does not negate the need to practice really superb PPE skills. Wear your mask as instructed. Remember hand hygiene, and especially donning and doffing PPE, and a reminder around physical distancing. They're the best measures we have to protect ourselves and our patients. So big thank you to everyone. And I'm going to hand it back to Aaron.
Thanks very much, Leslie. Proof to the adage that an ounce of prevention is worth a pound of cure. So there you go. Next up, we have our VP of Human Resources, Michelle Leroux, who's going to give us an update on some exciting news this week around pandemic self-isolation pay. Michelle, over to you.
Thanks, Aaron. And yes, thrilled to be here to talk about self-isolation pay. So this was announced just yesterday as part of HHS's ongoing pandemic response. So this is a temporary time-limited measure that we put in place until March 31st, 2021. It is, of course, subject to the progression of the pandemic and other related government orders. So who does this apply to? So there's really two areas. There's qualified asymptomatic employees who either by our own HHS employee health group or public health have been asked to isolate as a result of a workplace or a community exposure. So that's group one. The second group is employees who are scheduled and off work for COVID-19 related illness or symptoms, and they're not eligible for sick pay. Next slide, please. Some important things you need to know. There are assessments on a case-by-case basis to review the circumstances by the hospital. If you're required to self-isolate as a result of travel, you will not be eligible. Many of you, I'm sure, asking, because this is retroactive to the summer to August 10th, when will we be moving forward on that piece? It is, I'm afraid, a little bit complicated and administrative, but we are on it. Please be rest assured. So stay tuned, more to follow on the retroactive piece. But on a go forward basis, we're ready to go. Your leaders and others are provided with coding, and we're all set to make this happen. And of course, we'll prioritize the retroactive as quickly as we can. Please, again, your support and patience. We appreciate it so much. It is a process change and it's complicated, but it's a great news story. So we're thankful to our leaders, our staff, our union partners, everyone, as we work through this. And some really great information on the hub. I don't think I ever end an HR update without a plug for going to the hub. We've got some great FAQs. We update them regularly, for example, following this town hall with questions that will arise. That experts answer that aren't me, definitely, like our great health, safety, and wellness team. So please stay tuned, and more to come, I'm sure. And back to you, Aaron.
Thanks very much, Michelle, and to all our presenters. So now we have an opportunity for questions. Remind our participants, please try and use the Q&A function as opposed to the chat. We'll save chat for celebrations, Q&A function for question and answer. You can start. We have a list already. Why don't we just jump to it here? Maybe Leslie, I'd ask you to come back on camera. I think the first couple are around logistics related to our vaccine effort. In particular, I think it would be our intent then to provide some documentation showing the new groups for vaccinations.
Yeah, sorry if I didn't state that clearly. Yes, with St. Joe's, we will republish a sequencing framework with the new categories. The language is pretty simple. It's the highest people to be vaccinated, the very high priority to be vaccinated, the high priority to be vaccinated, and then moderate. And people don't have to re-register. I was kind of scanning the questions. If you were in sequence 1 before, we know you're going to go into the highest priority. If you were in the old sequence 2 and 3, you're going to go into the very high sequence. So it aligns very nicely. It's just a different title, and we'll take care of all of that behind the scenes. If you're new to register, just go on through the hub. And again, if we haven't updated it, you'll sequence by the old groups. If we have updated it, and we will do a communication to just give you the new categories. But just the key message is go on and register. We'll get you to the right group, and we'll get a needle in your arm.
Sounds great. Another question here about reporting of information. I know some of us might have read in the newspaper this week about the newspaper was unable to substantiate who among health workers has been vaccinated. Is it true that that recording is not our purview per se to provide public updates on that? Can you elaborate a bit on how we're tracking and knowing as a hospital, even though we're not stating publicly who's been vaccinated?
Yeah, so we need to remember vaccine is a personal choice, and it's your personal health information. So it, again, is not our information to share. We absolutely do share the number of people, either from HHS or St. Joe's. We can say who's had their first dose, who's had their second dose. But beyond that, we're not even seeing the data at a unit level to say how many staff of this unit. Again, because it is your personal health information. So We have been sharing very transparently with the media the number of people, and it's reported provincially the number of people that have had first and second doses. We'll continue to do that. We're fairly confident that by and large, the majority of our teams have all been appropriately vaccinated. And we need to be mindful sometimes that, like, you might see your colleague in the clinic being vaccinated in the early days, and you might have thought, oh, do they belong in the right sequence? But we were also for a while doing caregivers from long-term care. So people could be there for a different reason that might not be known to you. So I hopefully I've answered the question.
Yeah, thanks very much. That's great. The question here, I think it was about when you were referring to forward-facing staff, does that include outpatient as well as inpatient?
Correct. Yeah. So if someone is in the language is, if your role has you providing direct patient care forward-facing, that you will be considered in either the highest or the very high group to be vaccinated. Makes no distinction.
I see a question here about signing up to volunteer at the vaccination clinic. Just want to point out that information is available on the hub, so you can go there. A very frequent question. It's nice to see so many people wanting to jump in and help out. I think you're off the hot seat for now, or maybe
off
as I go through the list. get off quick. Anywho, okay. Next up, I think maybe Michelle Leroux. This question is a good one for you. If an individual received WSIB coverage for 85% of their income while they were off with COVID during that retroactive period, does the new approach that we're taking mean now that they'd be eligible for a top up on that difference?
Thanks, Aaron. Yeah, WSIB is a separate benefit and excluded from self-isolation. I would suggest that person whoever's asking the question refer to our FAQ. We're going to add some more information about that, or they can reach out to Employee Health Services. But yes, WSIB is separate and apart and has different benefits and protections.
Thanks for that. Leslie, I think I'm going to have to bring you back on camera. Looking ahead here, we have some more questions about our vaccine process. I guess the first one here is about clarifying those that would have typically been in group 4, our quote unquote administrative or non-patient facing staff. When would they be eligible for the vaccine? I know it's like guessing game, but can you give us a sense?
Yeah, so the hard part of predicting this is, and you'll see this in the provincial document, is there's hospital workers, but the new sequencing also aligns with the community workers. So we're very much working with the community hand in hand as the vaccines roll out. So I don't have a timeline yet as to where back office people who are able to work remotely from home, people who are working in non-clinical areas. We don't have timelines for that. We're in the process of trying to actually do the counts between community healthcare workers and the hospitals. What we do know is we are receiving around 5,800 doses a week. So we're hopeful we're talking, a couple of months, but I do not have a definitive answer.
Got you. And then a question here about, I see, first of all, I want to just mention, I see Kavita Damanaskar with a hand up. I will get to your question in a minute, Kavita, just in case you raised an error, which happens on occasion. Leslie, I'll pose this next question to you and then we'll go to Kavita. Is there any way that a first dose vaccination can be given in an appointment like the second doses are being given in an appointment? I believe it's our intention to schedule all first dose and second dose.
So what happens, you register in the tool. The tool has a randomizer, so people's names come forward in a random way based on the sequence we're pulling. And someone from the scheduling office will reach out to you. Again, a reminder that the phone calls will come across from an unidentified phone, so no caller ID. So be prepared to answer that no caller ID call, and then they will work with you to schedule that appointment with a little bit of flexibility. The second doses, we haven't had that same flexibility because we had thousands to get in very tight timelines. But first dose calls, we'll work with you.
Sounds great. So now we'll go to our live question from Kavita. Kavita, I've sent you an unmute message, so you'll get to do that on your end and you can ask your question. Maybe nothing. Okay, we'll keep going while we look into that. If you're having trouble, just send a note into the chat forum and we'll see if we can get you sorted out. There's a question that's a few ahead, but it's a logistics one, Leslie, while I have you on camera. In terms of the vaccination of ALC patients, was that a one-time event or is it something that we'll be continuing to do going forward?
No, so that is a piece of work that we're working with public health, and Sue Ann McAlpine's been leading that work on behalf of HHS Pharmacy. So at the point of which patients are designated ALC, we'll be looking to have processes in place to get them vaccinated. Likewise, we realize someone from a retirement home might come into hospital and be due for a second dose. It's a little complicated because we never want to open a vial of vaccine that we don't have a plan to use all of the doses. So it might not be, you can order it today and get it, but we're working through all those details and we'll share that with our clinical teams.
Good stuff. Thank you very much. Dr. Mertz, there's a question here about the vaccine and its prospective impact on the number of cases in the community. Can you comment at all about, I mean, we're still at a very early effort in that stage in that effort, but when, you know, given the kinds of things Leslie's talking about, when could we expect to see some kind of impact in the community as we vaccinate more people?
Yeah, I think that will take at least another couple of months, right? So probably once we see 20 to 30% of the population vaccinated, we may start to see a signal from that. I mean, the data from Israel is very reaffirming. So it takes several weeks from having vaccinated a large amount of your population, and then you see the decline. And what they see very nicely in Israel is the decline in those who have been vaccinated based on their age, while there's no effect yet on the younger population. So it's not a herd immunity situation per se, but what they achieved at this point of time is that those who have been vaccinated no longer get sick, right? And that's certainly the first goal that we have is vaccination. So all the positive effects in terms of preventing severe disease and death among those at highest risk will make a big difference for us in the healthcare setting as well. But I would say at this point, we are far away from that. By far, I mean, I think we need to look at the other couple of months. For long-term care, I'm very optimistic that we actually already see an effect there. It's hard to say right now because community transmission has decreased significantly. So we wouldn't expect as many long-term care outbreaks anymore as we would have had a few weeks back. But I'm very optimistic that we are able to tolerate more community transmission now and still keep the long-term care facilities safe.
Thank you for that. There is a question here too, maybe you can give some insight. Like if somebody has had COVID-19, how long should they wait before they get the vaccine? Is it something they would individually discuss with their doctor, or any insight you could provide on that?
So we don't have great data on that, and that's why there's no black or white rules around this. I would agree with what the federal guidance is, which is in a setting of limited supply, which we certainly have, to wait 90 days for those who had a recent infection. Rational being, probably with the first vaccine or the first shot doesn't make an awful lot of difference because you already have your natural immunity. There's even people suggesting, which based on the studies I've seen makes perfectly sense, that someone who had a natural infection probably is as well off with just the one vaccine rather than requiring two. So you had sort of your first vaccine with your infection, then you get one booster as everyone else would who hasn't been exposed to the virus per se. Hasn't translated into any guidance at this point. So current guidance is you still get your two vaccines with Pfizer or Moderna. You can well wait the 19 days, give someone else priority who doesn't have natural immunity, and then make sure that you get at least the one shot. Maybe things change in 2-3 months from now, or you will get both.
Thanks for that. Still so much to sort out. I know we've had a really robust Q&A today. We are getting close to time, and I want to leave some opportunity for celebrations and to close out. So I think I'll transition away from the Q&A now, but recognize that there are a number of questions there, which rest assured we will capture them where it's possible. We'll reply to people individually, and where additionally possible, we'll post an answer in the ongoing record of information available on the hub. You can also always, in between this and our next town hall, email questions to the HHS news at hhsc.ca inbox, which is a place we go to try and shape the content for these webinars. And also then you can get a reply directly back. So we'll go to celebrations. Rob, if you wanted to join me, we can do that. I'd encourage anyone that wants to give a shout out to a colleague or to a team, or recognize something that you've experienced or seen across the organization that you think is worthy of celebration. You can type something into the chat inbox, and Rob or I'll read it out. You can also raise your hand in the attendees section, and we'll do our very best to get you on. So celebrations, and also our panelists, should you wish to call anything out as well.
Yeah, maybe I'll just kick it off by, I'll join Les Gauthier by thanking all of our schedulers for all that they're doing to get people in for second doses, and just encourage folks that if somebody reaches out to one of our schedulers, maybe in addition to responding to them, you could thank them for the good work they're doing.
Good stuff. Thanks for that, Rob. Sharon, I see you coming on camera. Did you have something you wanted to call out?
I do. Thanks, Aaron. I wanted to acknowledge our home and community care partners. You know, through this entire pandemic, they've had this challenge of traversing the hospital system and the community system in dealing with, I'm sure, lots of directives that they need to manage, and at the same time trying to keep our hospital flow going. So they have had quite a task through wave 1 and wave 2. And I just wanted to say thanks on behalf of your hospital partners with our community care partners.
Good stuff. Thanks for that, Sharon. Well, final call out to our attendees. If anyone would like to raise their hand, we can call on you to give your celebration live. If anyone would like to type something in, we can read it out.
I think we got Les Gauthier again.
Yeah, I missed being not on camera for a few minutes. I did acknowledge this yesterday at the PPE task force, but would really like to acknowledge with all of HHS, and that is, I'm not sure if everyone is aware that Dr. Sarah Khan was nominated for a Woman of Distinction Award for all of the work that she's led for HHS, for our patients and our teams throughout the pandemic. So just really want to celebrate Sarah's contributions and the fact that she's being publicly acknowledged. She's absolutely great to work with and has done awesome work for us. Thank you.
Nice, very good. Nice recognition. Okay.
See, Dave's come on camera, Aaron.
Oh, great. Jump in there, Dave.
Yeah, thanks. Well, just, I mean, I wanted to actually thank, I think I did this last time, Aaron, so it's like twice in a row, but I wanted to thank your team and Michelle LaRue's team. Like, what's in concept, a very simple thing to try to provide the self-isolation pay, very, very difficult to work through, very complex, and communicating it, and a ton of work went into this, and we'll continue to go into it, and it's all in great support of our staff. But I just wanted to say thanks. It was a great piece of work.
Nice. I do see there are some questions that came in today on that, so rest assured everyone will continue to answer. It's still very much a work in progress, but to Dave's point, some really welcome news, I think, for everybody. All right, well, I think we'll wrap there. Rob, over to you for final remarks. We'll see everyone next time.
Yeah, thanks, Aaron, and thanks everybody for coming today. As I started off by saying, really very grateful to everybody for all that they've done and continue to do in this very difficult situation. We are experiencing a bit of a lull, although, you know, as we heard from Dominic, there are some clouds on the horizon, and it is a very difficult concept to think that after all we've been through, that we may still yet have some very difficult times ahead of us, but notwithstanding that, we will get through it. we are in a bit of a lull today, and for the next while, I would expect. So I know not everybody will have a chance to do this, but if you do have a chance to take some time for yourself in the coming week, 10 days, 2 weeks, I just really encourage you to do that, to try to regenerate a little and take advantage of this time. I know not everybody will have a chance to do that, but if you do, I would just say you should take the time, because we haven't finished the fight yet. So please do that. Anyway, I hope everybody has a great rest of the day, rest of the week. Thanks very much for joining in today. Cheers, everybody.